Two, one. Sir, we are live now.
Right. So, good evening, everybody. Thanks for joining this webinar on TCVO and DFO. At the outset, I'd like to thank the IOA and its president for giving the opportunity to being chair for this subcommittee for this year. And as all of you know, this is the sixth webinar in the series. And today we have Dr. Milind and Dr. Mangal to speak on TCVO and DFO. And then we have a panel discussion. So as we have discussed before, we have a large population of OA knee, which is 46 millions. We have the need to sit cross-legged and squat on the floor for activity of daily living. And as the patients present late, so we have to think differently. And for this TCVO, and in cases when there is a deformity in the lower end of the femur, the distal femoral osteotomy helps. And to learn this, as I say, there are three domains of learning. One is knowledge, and by these webinars, we are equipping you with the knowledge about knee preservation, which will help you to change your attitude by listening to the various speakers from all over the country. And then on 13th December at Lucknow, we have a pre-conference workshop. The registration is open and all are welcome to join. Seats are filling fast, so don't delay registration and ask your colleagues who are interested. The objective of the treatment is to conserve the knee for life. And if knee replacement is done early I mean before the last 10-15 years of the life, then it would not last a lifetime. But as the patient approaches early, we have to tell them the role of lifestyle modification, weight control and exercise. And as people are getting more and more aware about various types of fasting, especially intermittent fasting, this is helping our cause. We have discussed about the success story of HTO. And this present two talks will be the extension of the same. And remember, knee replacement is internal amputation and it does not match the normal knee. There is another word of caution. Industry is trying to propagate UKA as a joint preserving surgery, which it is not. And now we have to learn the difference of various types of osteotomy. And to start with, open wedge high degree osteotomy and STO are not synonymous. We have to specify which osteotomy is being planned. So the objective of today's webinar are we will be discussing about tibial condyle valgus osteotomy known as TCVO and distal femoral osteotomy when the deformity is in the lower end of the femur. When the lateral distal femoral angle is more. To be followed by panel discussion. So to start the treatment, we have to have a full length X-ray, and then we have to draw the mechanical axis, and then we draw the mechanical axis of tibia and femur, join the joint line and measure the angles as described by Pele. And this helps us to define whether this patient will require distal femoral or proximal osteotomy. And having decided that if the deformity is in the lower end of the upper end of the tibia, then we draw lines for medial open wedge osteotomy. We define the hinge, draw the connecting line between the hinge point and the center of the ankle joint. And this line 2 is rotated until it crosses the line 1. The angle between the line 1 and 2 is measured, and this is transfers onto the upper end of tibia with the hinge point just proximal to the proximal tibio-femoral joint. Now today we'll be discussing the situations where it is not possible or it is not advisable to do a medial open wedge higher tibial osteotomy, especially when the deformity is large or when there is intra-articular pathology and which leads to tibia vera. In these cases, TCVO is done, and for this we will have Dr. Milind Chaudhary to tell us more about how to measure these deformities, and if the deformity is at the lower end of the femur, then distal femoral osteotomy is done, which Dr. Mangal will be telling us now. So for distal femoral, we draw weight-bearing line, mechanical axis of tibia femur, and we measure the angle as advised by Broad-Pele. And when the deformity is in the lower end of femur, our DFO close wedge lateral base is planned, and the connecting ledge line between the center of the hip to the hinge joint, and the fixed point in this case is the ankle joint, and the angle which is formed between the line 2 and line 3 is what needs to be corrected. We rotate the line 2 onto the line 3, and this angle is transferred to the osteotomy, which is close wedge on the lateral side in the lower end of the femur. This could be, we can make a paper drawing and see, followed by we'll have panel discussion. And for the first talk, the talk on TCVO, we have Dr. Milind Chaudhary. He's a professor at Russian Vizaro Scientific Center for Respiratory Traumatology and Orthopaedics at Kurgan, and he's also editor for the Journal of Limb Lengthening and Reconstruction. For the talk on distal femoral osteotomy, we have Dr. Mangal Parihar, who's the advisor for us at IOA Knee Preservation Subcommittee, and he has a special interest in finding out solution for osteoarthritis knee, besides his passion for external fixator, infection control, and complex fractures, non-union deformity corrections. And our panelists are Dr. Thakkar, who is member of IOA Knee Preservation Committee, and he's also Joint Secretary for IOA this year. We have Professor Ravi Mittal, Professor from All India Institute of Medical Sciences. He is one person who is totally convinced about the success of knee preservation, and it is always a pleasure to talk to him about his passion. We have Dr. Ajit Saigal from Varanasi. He is currently the General Secretary for SAR Orthopaedic Association, and he has devised a grade for himself. For word of wisdom, I will request Dr. Dinesh Thakkar, who is Joint Secretary, to say a few words. Over to Dr. Dinesh Thakkar.
Good evening, everybody. I'm happy to be a part of knee preservation subcommittee, and on behalf of Indian Orthopedic Association, we are very thankful to Dr. Sanjai Rastogi because he has done a lot of efforts for organizing the webinars. That is the 6th webinar, and all these efforts have created some impact in the young orthopedic surgeons, and many orthopedic surgeons are encouraging the high tibial osteotomy. That has been proven when they write about high tibial osteotomy on their files, those files given to the patients. And this is the 6th webinar. I am very happy that I am a part of it. And now I think I should not take much time, and I hand over it to the next speaker. Thank you, sir.
Dr. Mangal Parihar, please.
Right. Thank you. So, I'm going to kind of, relatively speaking, a little newer concept compared to that of the osteo, part of the same family in terms of how do we achieve appropriate realignment. So, assume that realignment works, right? There's a lot of data which shows that realignment has got good long term. Looking at is a hip to knee to ankle angle of about 183 to 180. The mechanical axis should be passing through the Fujisawa point, and that basically is a point which is at the base of the lateral tibial spine. This is sort of conventionally accepted for realignment of the knee. Now, therefore, for this realignment surgery, we need to first of all define where is the deformity. And for that, we do the planning. And you may find that the deformity is in the tibia or it is in the femur. Now, when you have an LDFA, lateral distal femoral angle, which is marked by the red arrow, which is more than 90, in this case it is 93, and an MPTA, which is less than 85, marked by the blue arrow here, has an increased JLCA, joint line convergence angle, which is more than 2 degrees, which is marked by the yellow arrow here, and in this case it is 5 degrees. So here there is the tibia contributing, there is the femur contributing, as well as the JLCA is contributing to that. The other thing we look at often is the TVVA, that is the varus angle in the proximal tibia, and that is essentially the angle between the center point of the tibia here, the center point of the distal tibia, that is the green line, to that is the mechanical axis of the tibia, and the perpendicular to the articular surface, which is marked by the yellow arrow here. So this usually indicates, there are papers which show that if there is abnormal TBVA, then the results of a HTO are better. Now, conventionally, when we talk of deformity correction, we talk of proximal axis, distal axis, and we talk of cora shown here by the yellow arrow. And if you do your osteotomy at the cora, you will get perfect correction as well as realignment of your but in these situations, we are not able to do this if you do it distally. that is the cora is up there and the osteotomy is done distally, and you do an opening wedge or a closing wedge, you will find at the end of correction, there is a translation of the axis. So in these cases, oftentimes, we either have to overcorrect, like here the deformity is only 30, but it's been overcorrected to 41 to get your MPTA into the range. But the proximal and the distal axis are a little translated to each other. In that situation, we do the translation. But here, like if we are doing a axis planning, as I pointed earlier, the LDFA is 93, MPTA is 82. So this guy needs an HTO definitely, but also he probably needs a DFO. Correction, there will be iniquity because you will have to overcorrect the tibia to compensate for the deformity. If you do a distal femur osteotomy as well as a proximal tibial osteotomy as seen on the right side, where you do the tibia 13 degrees and femur 5 degrees versus only tibia, then you notice this joint line is not oblique, is on the left side. So the correct location for correction is in the femur. If you do overcorrection in the, you will need a large gap or a large wedge. Lateral hitches can occur when you're doing large corrections, and as I said, an oblique joint. Now, valgus femur and a varus tibia are definitely bad because that leads to a shear force which for increased osteoarthritic changes. Varus femur, valgus tibia is not such a bad compared to valgus femur and varus tibia. But still, if I say that this patient is ultimately going to require a knee replacement, if I'm doing these osteotomies, if I say that osteotomies last for years, by 65, 70, that patient may require a knee replacement. So my aim is also to try and keep this knee in a position where a knee replacement surgeon doesn't have too much problem. Now, I have enough anecdotal evidence of my own cases about this femoral varus. We have done overcorrection. As you notice here, right? We've done all the correction in the tibia. We've not done any weakness, and the hope of trying to avoid two surgeries. This is at the joint. Fine, the patient doesn't have any problem. So, anecdotally, yes, I know that oblique joint line may not have trouble, but if you look at evidence-based medicine, the oblique joint line is supposed to lead to poorer result because of the same thing that I talked about earlier, that is relaxation or shear, or changes the contact areas and meniscal loading on the medial side. Now, how do you do this femur osteotomy? The way I prefer it, though those are also described, I prefer to do lateral closing wedge and try to get the LDFA, that is the lateral distal femoral angle, between 85 to 88. 88 is normal, 85 is the lower side of normal. So I try to get it to the lower side of normal. That means if I will have less correction to do in the tibia. I like to do it in this biplanar fashion, similar to the open wedge that is done for the tibia. So there is a wedge which is essentially centered somewhere around the point where that flare is going into the shaft. And when you look at it from the lateral, there is this wedge and there is the other vertical portion. Now, what's the importance of getting it over here. There is a lot of soft tissue attachment over here. Your gastrocnemius takes origin from here. So there's a lot of fibrous tissue over there. And you don't want to go into the condyle. But this region, because it is bridged by fibrous tissue, is relatively safe from hinge fractures and displacement after hinge fractures. So that's what we are planning. And what you see, this green dotted outline, is that vertical limb of the biplanar osteotomy. The advantage of the biplanar osteotomy is this: you are not, your patellar tracking, etc., is going to happen in this area. So therefore, when you do this biplanar, you're keeping the area where the patella is going to track, you're keeping it sort of pristine. You have two flat surfaces which will prevent rotation, and because it's a broad surface, that will improve healing. When we're doing this DFO for a varus femur, the implant I like to use is a medial distal femur of the opposite side. This plate is meant for the medial. In comparison to the standard lateral distal LDF plate, which is the conventional plate for open or close, this is much more low profile and it does not irritate. So if you're doing left DFO, we use the right MDF. And this works very well, especially with the biplanar. The surgery in itself is not very difficult, in the sense this is a standard lateral incision, slightly shorter than the length of the plate. Here you see we marked the joint line, we marked alignment rod on the femur, we marked mechanical axis of the femur, incised the lateral intermuscular septum slash the iliotibial tract, and the lateral musculature is exposed. This is where the laterature is kind of ending. And starting over there, we raise that from the posterolateral aspect, from the lateral intermuscular septum, as well as from the femur. So once you've done that, you can incise the over here, and then raise the periosteum anteriorly, almost a little beyond the midline, and raise the periosteum on the posterior aspect. Raising it posterior aspect is especially important because you're going to be using a power saw over here, and you want to keep all the posterior soft tissues protected. Once we've got that space, we can protect it with Homer, and then put in 2 wires to mark out or delineate the area of your osteotomy that has been measured according to the previous. So here you have the distal wire, here you have the proximal wire, and both of them sort of tend to meet at that point which I showed you on the sawbone and on the X-ray. You can put 2 wires for each limb. That will help to prevent, angulation in the front. Get procurvatum, recurvatum. I found that if I'm careful enough with putting 1 wire, aiming for just proximal to the medial epicondyle, and this is the wedge that was planned for a little short of the view for the wedge section and the biplanar cut is ideally to use a new saw blade, or at the very least sharp saw blade which is used for more than 4 or 5 times. The moment I find that there is a little bit of difficulty in terms of cutting the bone, I will immediately ask for a new saw blade. This prevents thermal necrosis and, more importantly, allows an accurate cutting of the wedge. So now here you can see the wedge has been excised. That's the saw going along the wire. But on the left side, you see that the wedge on the posterior 2/3 has been excised, and the red is pointing to the vertical of the cut, which you can barely. And that's again the advantage of a good blade, because then you're not. We use the thinner blade of on the Synthes set, not those thick 0.9 mm blades which are used for. If you do this carefully enough, you can keep the wedge intact on the medial side. Very, very doable. And this is what we are able to do routinely. That green arrow is pointing to the biplanar cut, which is sliding as the wedge is closing and opening. A little bit of time. You can't do it in one jhatka, so to speak. You have to do it a little bit, give it a little time for elastic deformation. Again, a little. The hinge on the medial intact as we are opening and closing the osteotomy. We then keep that osteotomy closed, as you see right picture, and put rod between the center of the knee and the center of the head of the femur, and then use this protractor, what I call Sasta navigation, to measure what is the angle that we have got. If we have got an angle which is less than what is required, then if need be, you can cut out a little more in terms of the wedge. And once I'm happy with the angle, then I will place the plate on the side of the bone, confirm its position in terms of its distance from the joint and also its lie on the latitude. I first fix it with K wires, confirm this position, and then fix it with screws. So here fixed the distal screw, and we are proceeding to complete that distal fixation. I will fill in all 4 screws on that plate on the distal before doing anything proximally. You notice that one of those pink studs has been to keep the plate slightly away from the bone. This allows us to aim for of overcorrection by using the golden screw. So that golden screw is a cortical screw which holds obliquely into the femur. And if you find at this point that your alignment is still not perfect, you can just take out this stud from here, tighten this screw, more valgus, a degree or a couple of degrees into the femur. And this position again, confirm the alignment by measuring the LDFA as I told you. And if I need more, then I take out this stud and compress this a little more. And we then finalize the fixation by putting in locking screws in the proximal fragment. Whatever wedge has been removed is crushed and put on the back. And you can see, this is a slightly oblique X-ray, but you can see that biplanar cut, which is now, so that leads to really good healing once that biplanar cut is there. Post-operatively, these patients of the knee as much as they can, touch down weight bearing. In terms of the femur itself, I would say about 3 or 4 weeks touch down weight bearing, and then increasing weight bearing should be all right. But often, as I said, these patients are people who need a distal femur osteotomy as well as a high tibial osteotomy. So we may delay their weight bearing for about another week or 2 based on what the tibia is doing, because on the tibia I usually tend to do an opening, but I think increasing weight bearing from 4 weeks onwards is pretty safe for these patients. So in conclusion, whenever the LDFA is more than 90, and especially thrust in the gait, you should consider a distal femur osteotomy. The osteotomy should be done such that it is oblique, in the sense it is higher on the lateral side, lower on the apex is lower on the medial. Allows you the bone. I would go so far always do a biplanar cut, because that is very, very stable. Closing wedge, in spite of any worries that you may have that, oh, this is going to cause shortening, I don't think that 5, 6, 7 millimeters of excision of the wedge causes any significant shortening. And use an MDF plate of the opposite side, the medial distal femur plate of the opposite side, that is much more low profile and causes less problems than the actual lateral femoral plate. The lateral femoral plate is very similar to the fracture plate, but if you keep your wedge on the medial side, then just you need to sort of close the book, and this medial plate opposite side is quite competent to undertake that. Thank you. You need to unmute, Sanjay.
I think we can take some questions now, or do you think we do it later?
Either way, I think Milind can finish speaking,
Right.
and we can discuss
So,
both of them together.
Welcome, Dr. Milind. Thank you for joining, and you will be telling us about the TCVO.
So actually, Sanjay, I just got in here. My background is blurred. Otherwise, I would have loved to show you. This is the beautiful Wangchuk Hotel in Mongyar in Bhutan. This belongs to the king. And I just got here 5 minutes back. So I'm going to take 5 minutes to settle my presentation. So in the meanwhile, you could take a question or two. Please feel free. Let me sort my presentation out.
Yes, Dr. Mittal, you.
So this is a question regarding the osteotomy. How is the lateral closing wedge different from the medial closing wedge? Are there any differences, or it's just the same?
They are very similar, except that the base is on the lateral side, and the hinge, I mean, the placement of the hinge. Even for the medial closing wedge, you tend to do the same oblique kind of osteotomy, where the base is slightly higher and the apex. The point is also similar in the sense this is just above the lateral epicondyle. So again, that is sheathed in a lot of fibrous tissue, which bridges from the proximal fragment to the distal fragment. So even if by mistake sometimes your osteotomy extends a little into the medial edge of the bone, this fibrous tissue and the origin of the gastrocnemius, etc. If you ever try to lift the gastroc from that portion of the tibia, you will have of the femur, you will have noticed that this does not go with a periosteum. It requires sharp dissection with a good knife. Yeah. So that's how well that soft tissue binds over there, and that is a big protection for us in terms of unlike in the tibia, where if hinge breakage happens, that's a very, very difficult situation in the sense that can be pretty unstable. In the femur, if there is just a little crack going there, and you are not terribly aggressive about your osteotomy, etc., if there is a little break or the hinge fracture, that usually does not lead to any trouble.
Okay, so how do you ensure that the triangle that you are taking out is isosceles? Because if it's not isosceles, there can be a mismatch from the width of the proximal and the distal fragment.
Yes, so that's exactly why we those wires in terms of the wedge. So that has been determined. Let me just share my screen for a moment. I'll show you again. In terms of what that angle.
So you will have to tell us how much oblique that.
Should be,
Yes.
whether your angle is appropriate or not.
Yes. Are there some, like in the tibia, there is a.
Have an error, it's going to notice here, after we have closed looking, it's the same. So the maximum mistake you can make when you are oblique like this, a lot of this is done during the planning only, that this is, this is how we are going to do it. But the maximum mistake you can make is maybe a millimeter or a couple of millimeters. See that? So here you could argue that, okay, there is.
No, that's
I don't
minimal.
think that really matters. Yeah.
That's minimal.
No.
So are there any landmarks that you would tell us from the lateral side that ensure that the osteotomy is isosceles? Did you
Sorry,
get my
I didn't hear that. I think no, I didn't get it. Tell us from the lateral side, that much I heard, then I didn't.
are there any landmarks to follow? Bony landmark that from where we can make the osteotomy so that it is isosceles triangle, or is just your judgment?
There is a not a bony landmark, but there is this similar to what you have on the medial side. You have these three perforators. On the lateral side, there is nothing which, okay, this is where you need to go. So usually it is based on my planning in terms
Okay.
of where I want to start.
Okay.
That's about it. Medial side, there are those three vessels, the three sisters or something they're called, which tells you the level of the osteotomy. On the lateral side, there is nothing. But it's not terribly difficult. I mean, once you've done the planning and confirmed on the plan that the bones are meeting more or less without too much of step off, you can then confirm the same thing on the CR with the wire before you make the cut.
The problem would arise when the wedge is bigger.
Yes.
Wedge is very small, then usually we will not have a problem.
Yeah.
Because, I don't know whether you can understand what I say.
I understand.
Yeah.
So
Okay.
small wedges, there is a little bit of difference only, so that it doesn't make a difference. Large wedges, there is a potential for a large difference.
Yeah.
So the only thing is, that's what I said, that you can actually C-arm, you can from point B and then swing something to measure point, the hinge point to the other, and those normally when you do it, this is not a deformity correction in the true sense of the word. Who had epiphyseal arrest and developed 15 degrees of varus, this tends to be
Very gentle.
and therefore these wedges will be in the range of 5 to 7 millimeters at most.
Yeah.
So when you're doing a totally different issue, and there the point that you made is valid, and you can measuring that actual time.
Okay. In the tibia, when we're doing a biplanar osteotomy, it is recommended that we do in a ratio of 2/3 and 1/3. 1/3 for the oblique one. And
Same thing.
so in the femur also it's the same or it's different?
Yeah, it's the same. That's why I said, except in a small Indian lady where that femur is pretty small, तो उसको फिर 2/3 1/3 divide करने में थोड़ा सा मुश्किल हो जाता है. But otherwise, most patients you are able to do that 2/3 1/3 ratio, because you want enough thick bone on the front, it should not break. So in a very small bone, if you try to do this 2/3, 1/3, then that front portion will be pretty flimsy anyways.
So how long would you suggest should be the, say, in a, say, a coronal plane osteotomy, the one which is oblique osteotomy?
It's pretty long
How
actually.
long it should
It's
be
at about,
approximately?
I think, I would say it's about at least a couple of 1.5 to 2 inches,
Okay.
because that then keeps your entire patellofemoral area out of this thing, out of trouble. And if you are not, what happens is you have to be almost parallel to the surface of the femur. Allow that gliding which I showed you. If you are not vertical enough, then these fragments will abut against your very long slope, then they will slide. So it comes down.
Thank you.
Mangal, if I'm getting correct, what you're saying is that the lateral distal femoral plate is thicker than the medial distal femoral plate?
Much thicker, much thicker, and it tends to stand out. It is a cause for irritation, because the lateral distal plate is kind of originally meant for opening wedge, whereas the medial, nobody talks of an opening wedge. Medial was meant for a closing wedge. So a plate which is meant for closing wedge inherently,
Is
if you are,
thinner.
yeah, it can be a little less.
Right. So if there's some more questions, or we proceed to the next. Dr. Milind, if you are ready, then we
Yeah, I think so. I'm almost ready.
right.
Good evening, gentlemen. Good evening, all from the Kingdom of Bhutan. It's a very big day today. A lot of things going on, all over the world. There's also the Sarva Pitri Amavasya. So it's an interesting day you've chosen the topic on. So I invite you all to join me in two different things. I invite you, the audience, I invite everyone to join us for the HTO 360 conference that's going to be held in Akola very soon on the 1st, 2nd, and 3rd of December, where we are going to have an in-depth discussion about all aspects of all kinds of high tibial, lower femoral, and intra-articular osteotomies. And the registration link has been sent on all groups. Yours truly, Dr. Sanjai Rastogi, is very much going to be there as faculty. And I invite all of you, Professor Mittal, Dr. Mangal, Dinesh, and everyone to join, because it's going to be exhaustive for 3 days with a lot of surgical demonstrations. Now, having said that, the second part is I invite you to open your mind about the fact that now a high tibial osteotomy or a knee preservation surgery is not merely about deformity correction. It extends beyond the principles of deformity correction, because knee osteoarthritis has several issues of its own. There are issues that deformity correction principles and alignment cannot address. For example, there are issues of patellofemoral arthritis. There are issues of the joint line convergence angle, or there are issues of instability of the knee joint. This is not addressed by the principles of deformity correction. The second aspect of this is all of us have heard of knee instability, which consists of the ACL tear, the PCL tear, the posterolateral ligament complex. And we've heard of all of these terminologies. I invite you today to open your minds to an entirely different kind of instability, and that is the degenerative instability of the knee. I can surely tell you that you may have not heard of this term before. I can surely tell you that you have never read or heard of this term before, but there is such a thing as degenerative instability of the knee joint. And that is what can be addressed by an intra-articular osteotomy. Alignment is no longer king. Alignment is not the only king. Alignment is not the only God. Alignment is only one of the goals of corrective surgery, of reparative surgery, of knee joint preserving surgery. Achieving stability of the knee joint from the degenerative instability is one more such goal. So I request you, I invite you to open your mind to this concept, and I will share some brief videos. I think it was just 1.5 to 2 months ago that we had an exhaustive, I had a session on the TCVO. So I will show very briefly some of the, some of the concepts that we spoke about on that day. And I would like to then, show you a couple of operative demonstration videos and speak about these newer concepts. And I hope that will whet your appetite for the upcoming HTO 360 conference. But I would be remiss if I did not start by thanking the Indian Orthopaedic Association Knee Preservation Subcommittee, which is presided by Dr. Sanjai Rastogi. I thank Dr. Dinesh Thakkar and the office bearers of IOA. And so I would like to share my screen and have a brief, if I may, a brief look at, the presentation itself. And so can you see this, Dr. Sanjay? Dr. Sanjay, can you see this?
Yeah, yes, sir. Yes, sir. We can see it.
Which screen is visible to you? I'm so sorry.
Right now we are seeing a femur and
Tibia femur bilateral with plates.
that's it. It's like
Oh,
a
you're seeing
movie.
this one. Oh, it's part of a movie, is it?
Yes.
Okay. So give me a moment. I'll now this one I want to shut off. I'll show this in a bit. Okay. Is this visible now, the intra-articular?
Yes.
This is visible?
Yes.
Okay. Intra-articular tibial condylar valgus osteotomy. So I'm very happy to share with you that Professor Tsukasa Teramoto, who is one of the inventors of the tibial condylar valgus osteotomy, is coming to Akola on the 1st, 2nd, and 3rd of December. He has been performing this osteotomy since 1989. They started in Nagasaki, then he's migrated to Fukushima, Koriyama City. And he's done thousands of these already. And much of the scientific content is lost in translation. We first got to hear him at the Asami International Conference in September 2014, the international conference over which I presided. And I think it was one of the great highlights and one of the things that I learned the most from. And everybody was laughing and everybody was kind of, very skeptical and saying, "Ye kya chal raha hai?" He was showing folks who were 89 years of age. He's done this intra-articular osteotomy. It was, people were laughing and he said, "Yeah, you can laugh. Everybody laughs when they see this for the first time." But I think he's having the last laugh because he is on to something. And fortunately for me, I've had the good sense to try and understand this. And I've performed more than 70 of these with remarkably good results. So let's come to this quickly. We all love this single type of HTO. We all love doing either the external fixation, but we know that Jackson and Waugh showed us so many different osteotomies. And they said that, because they performed 22 different types of osteotomies. And, as a parting advice to young surgeons, they said that you can do whichever operation you're most comfortable with and has the least risk of complications, and which is why all of us love to do one type. So Coventry did the closing wedge only, and for a while it worked, but he used staples and stuff like that, and it didn't last a long time. You can see even in this, there is a pagoda tibia over here. So a lot of the concepts are not understood. Cochino formalized this with a nice plate, barrel plate, and angle blade plate. He did the closing wedge osteotomy to get far better results because he did a great job of improving the techniques. He could get the patients to sit in Vajrasan. He wrote this article on improving knee range of motion, which is when I went and visited him in the year 2004. So he said that this is like a knee replacement without the prosthesis. It's an extensive surgery, which I again repeat, this is not merely a question of alignment. It's not merely deformity correction. There are many elements now. Of course, we know opening wedge osteotomy was popular in France, and they did many Debay and Hernigu. And the dome osteotomy of Mackay was very popular. And then came the focal dome, which I was fond of, and I did exclusively for the first 15 years with great results. And it worked for very many reasons. It was popularized by Maurizio. And then came the Tomofix system with Stobley, of whom Dr. Sanjai Rastogi is one of the largest proponents. But all of us, and then this trend about the double level osteotomy and the distal femoral osteotomy, which is being prescribed for the last 20 years as a sine qua non or as a must whenever the femoral deformity exceeds a certain limit. Some Japanese workers too have shown that it is necessary to maintain the joint line. But people have also said there are so many truths that are not yet clear, that joint line obliquity does not affect the results, except when the patient is young and has a high demand, is athletic, and he needs to do a lot of activities and sports and running. So here comes intra-articular osteotomy. Dr. Matsushita said that, there's only one osteotomy needed, and that's the intra-articular. But I would not go as far as to say that. And I'd like to share with you, this is Professor Teramoto. And so there's only 6 or 7 articles in the English language literature on intra-articular osteotomies. 3 of them are from our unit in Akola in the JLLR, which I invite you to look up on jlimblengthrecon.org. And so this is an editorial I wrote. Are different high tibial osteotomies needed for differing location and severity of deformities? So the answer is an unequivocal yes, because we have these large deformities combined with instability, and one osteotomy doesn't do justice to the kind of mechanical axis deviation. So, so I'll skip these steps and I'll come to we know these, so I'll come to the tibial condylar valgus osteotomy. And here you can see this is the kind of instability that is present. That's the teeter-totter in the joint. And we can reduce this by elevating the medial tibial condyle. And it reduces this instability because it improves simultaneous bony contact of both the tibial and the femoral condyles like this. And sometimes the deformity is huge. And what that does is the amount of correction we can achieve only with the intra-articular may not be sufficient. So we add a second extra-articular osteotomy, also to take care of the alignment issues in the really large ones, which is exemplified by this particular case. There's this really large deformity. You can see the amount of opening up on the JLCA and a point contact of the medial condyle. So the intra-articular osteotomy is done. Both the condyles are now collinear, and a second dome osteotomy is added along with the fibular osteotomy to give us a perfect alignment. So I'll skip these steps. We know this. What we don't know and what we are not aware of is the secondary deformity, which is the intra-articular. The intra-articular deformity is measured by two angles, the condylar plateau angle. That's the two lines drawn tangential to the tibial condyles. And they normally are collinear. The tibial condyles should be collinear. They should be at the same level. But we find very often one of the condyles is depressed, which leads to a point contact on the medial side. And what we can do is, redress this. We can elevate the condyle to make them parallel again. And this is what we are familiar with, the joint line convergence angle. And this is, causing a lot of confusion in the minds of people. For people who only perform the medial opening wedge high tibial osteotomy, they're using the JLCA. They're using the varus JLCA minus the valgus JLCA, that amount, and they're subtracting it from the correction. Some Japanese authors several years ago also said that don't use a standing X-ray for calculation of how much wedge you want to resect open in a medial opening wedge. You have to resect a certain amount which is lesser. And this confusion is because
Milind, can I just interrupt? Milind, can I interrupt you for a second?
Yeah.
I am not getting your voice. It's coming and going. Is that the same with you, Sanjay?
No, it's clear here.
Okay, sorry. Then it's my connection. My connection. Okay, no. I thought in case it's your connection, then you can stop your video. Sorry to interrupt. Yeah, go on.
No worries. So the joint line convergence angle is it's not clearly understood. That's because it is degenerative instability. And therefore, we have to tackle it per se. And the tertiary deformities which are present, they do play a role in the choice of the osteotomy and the choice of the hardware. And there is indeed a small role for external fixation in 5% of high tibial osteotomies. So we won't look into these ancillary measurements now. What's important is you do the thorough clinical exam, medial joint line tenderness, the patellofemoral tenderness, really check for the lateral joint line tenderness. And these are the crucial aspects. This much mediolateral laxity in full extension is what represents an intra-articular deformity. And when the patient walks into your chamber, you see this dramatic lateral thrust. This is where you should suspect. And when you record this under the C-arm, you're really looking at an intra-articular deformity. And that's what you need to correct. Okay. So there it is. And all of these are secondary ancillary features, which we're not going to look at. So I will share only the algorithm for the TCVO. So if you have either a small varus or a large varus with an intra-articular deformity, which I have shown, without the length axial rotation issues, a TCVO is indicated. And if you have a large varus with an intra-articular and the presence of a large rotation or length issues, which is when you perform the TCVO with an additional extra-articular osteotomy in younger people or those who can, accept an external fixator. So we'll skip these. And so these are simple examples of the TCVO. Initially has to perform a fibular osteotomy. Now it's not needed. You can see this JLCA, which is reduced. Both the tibial condyles are collinear like this, but it doesn't correct the alignment completely. So when you have a large deformity like this, you can see the mechanical axis is at minus 60%, and there's point contact of the medial condyle. Here we perform the elevation of the medial tibial condyle so that both the tibial condyles are collinear. But that's not enough to correct the mechanical axis, which can go only up to 30%. So we had a second osteotomy. Here with the classic lateral translation of the distal fragment. Here a fibular osteotomy is a must. And here we can be rewarded with a 60%, width of the tibial joint line is where the mechanical axis is passing. So we have covered all bases in these really large deformities. The crux of the matter is what the mind does not know, the eye cannot see. And it is time for us to open our minds. So how do we, again, I reiterate, how do we diagnose an intra-articular deformity? Clinically, when you see a large varus, you should suspect it. It's not confirmatory, you should suspect it. A dynamic varus gait on walking, is almost certain to be caused by an intra-articular, and this mediolateral laxity when you examine in your operation, in your consulting chamber, should point towards it. And I showed these three things again clinically: the gait, the laxity, which is recorded under the C-arm under anesthesia. Radiologically, you have a large MAD, you have a large JLCA, and you have an increased condylar plateau angle. In the Blount's literature, this is called the medial tibial plateau depression angle. So one of the tibial condyles is depressed, and therefore it makes a point contact like this, point contact. So they elevate the tibial condyle. They know this, they call it the MTPD. So this is a large MAD, this is a large JLCA, and this is a large condylar plateau angle. And very few articles, as I was telling you, the first was written by Professor Teramoto in JLR in 2015. This is one article by Professor Chiba's son, Goji Chiba, who was the co-inventor of this. And they spoke about this, 5-year clinical radiological results, and a few more, articles are there, very few. Recently in the Journal of Experimental Orthopaedics by Kuwashima, he wrote up about this, but they kept it in on purpose in the Journal of Experimental Orthopaedics. The truth is, this is established science for the last 30 years. Now, so this is a purely intra-articular deformity, and this is a combination of intra and extra-articular deformity, like this. So let's, these are some more articles that I told you about. This is by Higuchi, and he showed that what are the radiological features of purely intra-articular versus an extra-articular high tibial osteotomy. And, this was the article by Kuwashima, okay, which came up in the year 2021. So what we should be looking at is understanding is the degenerative instability part. And I showed you these animations. So let's take a look at this. This is the kind of the intra-articular osteotomy we perform. There's a vertical limb that goes medial to the patellar ligament, and then an oblique limb that goes down. And this angle is opened up till such both the tibial condyles are touching both the femoral condyles. You can see here the medial tibial condyle is touching, but the lateral tibial condyle is far away from the femoral condyle. So the point area of contact is there. That's the, that's pressure is equal to force upon area. So pressure is dramatically increased because the area is very much less. So you increase the area of contact. The entire tibial, medial and lateral tibial condyles are making contact. So here is this gentleman, he's a retired physician, and on one side he's had an opening wedge. So here are the steps of the surgery. We use these wires as guide wires, which point us towards the the intercondylar area. And this is the oblique medial cut in progress. And this is the vertical cut, and this is the oblique cut. And using an arthrodesis spreader, we spread this apart. And we can use the same principle. We can use the Miniachi method to find out how much wedge we are going to open up. But the actual on the table, it is a subjective thing. We stop the correction when the tibial condyles are collinear and when there is no more mediolateral laxity on the table like this. What we do is we ensure that the condyles are not separated by adding any elements from the Elizarov or the LRS set, which prevent the condyles from opening up. And we use the spreader here to ensure that they become collinear. And this is how the patient gets his result. The mechanical axis deviation is not as well corrected, but the instability is completely taken care of. And despite the mechanical axis not reaching 50, the patients have complete relief of pain. So we came up with some new measurements to determine the changes after this intra-articular HTO. And Sanjay, I hope the background noises are not disturbing you very much. Please let me know. Sanjay?
No, it is fine.
Okay. All right. So this is the spine edge angle, we call it, or from the top of the intercondylar notch, we draw a line going up to the medial and the lateral edges of the tibial condyles. And when we elevate the condyle, this angle is reduced, or when you take it from the obtuse angle, it is increased. So you know that you've indeed made a difference. And the second point is we draw a tangent, and you can see that this distance is reduced statistically significantly, even though it may be a 1 or 2 millimeters. What this actually signifies is that the cruciate ligament origin to insertion distance is increased. So the cruciates are tensioned, okay? So this acts in multiple ways. Firstly, what it does is it simultaneously contact both the condyles of the tibia with the femur. So there is no more mediolateral, toggle or teeter-totter. Second thing that's happening is the intracondylar eminence goes down so that the cruciates are tensioned, okay? So this is something that you can understand intuitively after you do several of these. And that's the mechanism. So some examples, this lady here, large deformities. On this side, I checked very, very carefully and I found no mediolateral laxity, okay? No mediolateral laxity. So I concluded that there is no intra-articular deformity. She has a horrible gait. On the right side, there's no intra-articular deformity. So what we did was a fixator-assisted plating, okay? Large incision, patellofemoral release, the dome osteotomy, fibular osteotomy, used a fixator, corrected this deformity, also corrected the PPTA, the tibial slope, corrected the FFD. But on the other side, she has this intra-articular deformity. So we elevate the medial tibial condyle, we fix this with a screw sometimes or not, and then fix with a plate and keep it open, graft it or not. And here she is with this kind of gait, walking fast, no pain. She can sit down, no patellofemoral pain, no instability, no instability. So this is the diagram from Professor Teramoto. He says, if you perform in instability, in an intra-articular deformity, if you perform only the opening wedge, what's going to happen is you're going to have a persistence of the teeter-totter, and the main pathology is not addressed. So, here are some more examples. This lady here, the large deformity like this. This is done very early on where I used to add bone grafts. You can see that the mechanical axis comes up to 45, but she has an excellent clinical result, no pain. So what the TCVO does is it corrects the JLCA CPA and only modestly corrects the MAD, but it takes care of the intra-articular instability and the intra-articular deformity. And that is how it gets rid of the pain, okay? So the axiom here is congruent contact and stability are more important than just the alignment. Now, the question is alignment dethroned? And what if the mechanical axis is undercorrected? The point here is that if we only look at alignment and we perform a distal femoral osteotomy, Mangal has given a very nice exposition of the DFO. I too love this surgery, but I can tell you it's challenging and it's difficult. Somebody was asking a question. It is difficult to restrict the closing wedge osteotomy to only 5 or 6 or 7 mm. If you go beyond that, there are articles in the literature that tell us that the incidence of hinge fractures can exceed 50%. And if you have a type 2 hinge fracture in a distal femoral osteotomy that goes up into the diaphysis of the femur, it is a very unstable situation. You better keep the patient free from weight bearing. The second thing that happens is if you correct a large amount and your MLDFA goes to 85 and beyond, then the patient has got a valgus KJ alone, knee joint line orientation. And to compensate that, the patient has to adduct the limb while walking, which is impossible and very troublesome for the patient. So it's better to correct. You think carefully in older patients. I agree in younger patients, those who are 50 and lesser, who have a large varus, femoral deformity, do the DFO. But in the older patients that come to us, the problem is degenerative instability, and it is easier to perform with a single osteotomy, the TCVO, or we can do more. We can add a second osteotomy. And these are some of the calculations that we use. That's when the amount of angle needed to correct the MAD to Fujisawa point to 60% is greater than the angle we achieve varus JLCA minus valgus JLCA multiplied by 1.5 is when you need to add a second osteotomy. Now, a second osteotomy can be a closing wedge or an opening wedge or a distal dome osteotomy. I have done all of these. And in the same plate, you can add a closing wedge, like in this lady, And even though she is not fully corrected, she has zero pain. Or you can add an opening wedge at the lower edge of the TCVO like this to achieve a better correction, or which is most reliable, is to perform an extraarticular, dome, which I have shown in this animation before. Like this, you perform the TCVO that reduces the teeter-totter in the joint by elevating the medial tibial condyle. And then you fix this with the half pins. The teeter-totter is reduced. And then you perform a second osteotomy an inch below and correct it to the desired extent, like so. This comes, as I said, from the Blount's literature, like this large deformities. You can see the depression of the medial joint line. And these are the double osteotomies we perform for the Blount's, which is what gives them the perfect correction. So this has been reported. So take a look at this lady, this large, teeter-totter. You can see the condylar plateau angle is large. This is a pagoda tibia. And here you can see both the osteotomies. Here the opening of the TCVO and the distal dome osteotomy. And here she is with a completely corrected intra as well as extra-articular deformity. Okay. Now, what I'm going to do, this lady, the first one that I did this combined now almost 8 years ago, like this, she has an absolutely wonderful result. What I'm going to do is I'm going to share a video of, this is the video of the TCVO with the extra-articular. Let's take a look at that. This is a patient who has got a very large deformity. Okay. On the right side, tremendous obesity. You can see the amount of varus. There is some MLDFA. Look at this dramatic deformity. He can barely walk. Tremendous instability. This is degenerative instability of the knee. The posterolateral corner instability that happens in athletes is not this. This is severe mediolateral laxity you can see under GA, recorded under the C-arm, this teeter-totter. So we start with the fibular osteotomy like this because we are doing the second one. And after having fixed the distal part, we come to the intra-articular component. In the intra-articular component, the patellofemoral release is done. I resect the osteophytes both on the medial and lateral side. Now I preserve the deep MCL, and having preserved the deep MCL, let me show this again. Having preserved the deep MCL, we remove the osteophytes, and what that does is it increases the instability, because osteophytes have been formed by the body to improve the stability. Okay, they're broadening the surface area, they're broadening the contact area. But since we are going to give the stability, I remove the osteophytes. They can be used as graft, and we check that the instability has increased. Now, what we are doing is we are taking the vertical limb of the osteotomy, first with wires, then with an osteotome. And this is the intercondylar area with the osteotome that's being cut very carefully in the lateral. You go down slowly posteriorly. You make sure you don't go into the ACL, and then you mark the curved cut, the anterior curved cut with wires, with thin osteotomes, which can be an oblique cut going down or a curved cut going up, as in the FDCO over here. And you make sure you do a complete cut over here, the posterior and the intercondylar element, and you spread it apart. We place these wires so that the bending of these wires is going to tell us that the condyles are now going up. And then we check for now you can see the instability is reduced dramatically. Very little instability remains. So then we fix this with the half pins on the medial and the lateral side. Okay, with the spreader in situ, also with the screw. And we put in the bone grafts. You can harvest a lot of osteophytes. It's wonderful material. We close this wound, and then we create a dome osteotomy beneath this. One ring above, and then we perform this osteotomy. We translate the distal fragment laterally. And here he is with a very good correction. As he's standing up, and the mechanical access is at 60%. And here he is walking a couple of days after surgery. His lateral thrust is completely eliminated. And only these people who are below 60 years of age can tolerate this surgery. He's hardly on the second or the third day. And this is what he's doing. This is how he has, we have done this surgery. And you can see that when the JLCA is well corrected in these surgeries, the condylar plateau angle comes down and the mechanical axis is also able to improve. So what I'm going to do now is I'm going to share, if I have a few more minutes, this is a video of the osteotomy known as the focal dome condylar osteotomy. What happens is that elderly ladies are incapable of tolerating this fixator. So what we do is this new can you see my screen now, Dr. Sanjay?
No.
You can't? Okay, give me a moment. I'll be able to, yeah. So now I share screen again. And yeah, let's come to the focal dome condylar osteotomy. Okay, so everybody is worried. You don't want to do external fixation. Yes, I understand. But if there's a large deformity, how do you ensure that the intra-articular osteotomy corrects the mechanical axis as well as the intra-articular deformity in a single osteotomy? This is the elegant solution. So there's going to be much of this at HTO 360 in Akola. Okay. So let's take a look. This is the lady with a large MAD minus 30%. Okay. MLDFA is not increased. This is her lateral thrust. What do? You need to correct the deformity very nicely. You need to correct the lateral thrust. All right. So MLDFA is only 87 and MAD is so high. So this is the JLCA 9.7, varus JLCA. Valgus JLCA is 1.8. So, the resultant, this is the mediolateral laxity in full extension, not in 10 degrees of flexion, in full extension. There's this teeter-totter effect. So much instability in the joint, okay? So what we do is we start by vertical midline incision. We are releasing the medial soft tissue structures. This is the deep part of the superficial MCL is kept intact. These wires give us a guide to the vertical cut. Now with these K wires, we are making and with a reciprocating saw or with wires or with osteotomes, we make these cuts in the intercondylar area, okay? And the posterior cortex is being cut like this, okay, with either broad or thin. And here you have this vertical cut near the lateral tibial spine and a curved cut which is going up. We use these lateral cortex protection wires, which are the Ilizarov 1.8 wires, which protect this thin, narrow zone. Then these 1.25 mm wires are passed here, which help you to see how the tibial condyle is going to be elevated. We make sure that the posterior cortex is really cut nicely. Again, very carefully under C-arm view, I'm showing you all the time we are using this. And now we are slowly spreading it apart, okay? You can see these wires are curving and we are putting in a spreader over here, until we are able to spread. But the bony contact is maintained here. And these condyles, the wires are bent and the condyles are making almost full contact with each other, okay, without overstuffing the joint. And we're maintaining this with a spreader. And then we pass in this. You can see this beautiful contact is remaining. But look at this, no lateral thrust, complete correction, complete relief of pain. Mechanical axis has gone up to 60%. Condylar plateau angle is 0. And the knee joint line orientation is well maintained. So this is I think the pinnacle. And this is her result. She's able to sit cross-legged. She has 0 pain. And this is several years after the surgery. No thrust whatsoever and no pain. Patellofemoral pain is eliminated. And there's no mediolateral instability. So what I would suggest is we open our minds to the fact that osteoarthritis of the knee is not merely a matter of malalignment. There are issues of the patellofemoral joint. There are issues of instability in the knee joint, in the coronal and the rotational planes. There is a loss of substance of the bone. The two condyles don't make simultaneous contact. And the cruciates and the other capsuloligamentus structures have become lax because of the excessive and abnormal forces. And an intra-articular osteotomy, the TCVO, and its newer avatar FDCO can take care of both these issues. And this is a very exciting time. And I'm surprised how in patients as old as 80 years of age, with this kind of teeter-totter, everybody has told them about total knee. The temptation for me also is to perform a DFO, but older people cannot tolerate a DFO and tibial osteotomy at the same time. They have high risk of infection. They have borderline diabetics. So I urge you to open your mind to this intra-articular osteotomy. And with that, I thank you again for this opportunity to share my experience and enthusiasm for this newfound knowledge that I have over the last 9 years. Thank you. I'll be happy to take questions.
Thank you, Dr. Milind, explaining once again. Dr. Mittal had a question.
Yeah. So in fact, I'd like to ask 3 questions to Dr. Chaudhary. What if you examine a patient for medial lateral laxity, that is quite variable in the population. Some people have lax knee, some people have, say, very stiff knees. And in the sports injuries, we just compare it to the opposite knee. And then if comparison to the opposite knee, if it is abnormal, then we take it as a pathological. But for consideration of TCVO over osteoarthritis, because that thing we are looking in a normal knee, which is not osteoarthritic. In an osteoarthritic knee, how do we assess the norm? What is normal medial lateral laxity according to you on clinical examination?
Yeah, so it's a very interesting question. I have initiated a study now using some sophisticated tools and video analysis. Just like you're talking about sports injuries. This gentleman, Volker Musal from University of Pittsburgh, Pennsylvania, has designed this test that he has graded the pivot shift test using a video analysis. We are doing something similar. And what we are doing is, of course, you check the other side. You ask the patient whether they have any pain on the opposite side. If they have no pain, it's not arthritic. This is not going to be, it's not going to be, if you flex the knee in 10 degrees, 15 degrees, you're going to get some laxity. But that is not what this degenerative instability is. I probably may run out of juice. So I'm going to try and, extend this to be able to answer your questions nicely. So the medial lateral laxity, I urge you to look at it yourself and check in your patients who now come to you with this kind of large varus. You will find that there is indeed instability. And you will indeed find that there is instability. And this instability, along with a large mechanical axis deviation or, large mechanical axis deviation is along with the increased JLCA. So it's a combination of factors. If you're not convinced, if you're not certain that you are going to be able to detect this instability just by clinical means, check under the C-arm, make sure you're in full extension, compare with the opposite side, and you will be rewarded when you combine your findings of clinical instability, when you combine the radiological findings of increased mechanical axis deviation with the condylar plateau angle and the GLC. It's a combination of all these factors that leads you to the correct diagnosis that this is an intra-articular.
Okay. My second,
yes, go ahead, please.
Whatever limited literature that is available in English language, if you read the slightly older publication by Dr. Shiva, he talks only of TCVO, and he says you open the joint osteotomy till you can't open it further. That's the only criteria. And he never talks about weight-bearing axis or mechanical axis. He has not talked about that.
That's true. That is also true for Professor Teramoto. He
Yeah.
does say that you aim to get the mechanical access to at least 50%. That's what Professor Teramoto says. And to his credit, he is saying that. So we do. So everything evolves. So I presented this, Professor Mittal. I presented this in Japan recently in Koriyama City, and I still think that there is a role for a second osteotomy in some cases. Okay, everything that's original is not the only. Science progresses. You ask questions, you try to answer the questions. I'm sure you know everything progresses, everything changes. Yes, Professor Chiba's article do not talk about it. There is a language barrier. These people are not very well versed in English, and scientific articles, it may be a rare drawer Paley who's able to put everything very succinctly. But for example, how many articles have you found that really explain this concept of stretching of the cruciate ligaments? There are so many things that literature and the written word cannot explain. This is understanding.
I agree. The newer literature by Koreans and Japanese, they talk about the second osteotomy and also about the cruciate tensioning. So, just wanted to know if the results of Dr. Chiba were inferior to those published by Koreans and the newer Japanese people. Because adding a second osteotomy is not easy for people like me.
I found the answer to this question in the FDCO. Okay, I found the answer to this question in the osteotomy called the focal dome condylar osteotomy. All right, so everybody is reluctant. I can understand your reluctance. I had a reluctance to perform in the older patients the second osteotomy. Everybody is reluctant to consider a second osteotomy. But that is where I urge you to look at the focal dome condylar osteotomy. This is a gold mine that I discovered. Actually, my understanding of the focal dome condylar osteotomy is slightly different from that of the originator, that's Professor, from Kanazawa University, Professor Suchiya. It's a little different from him. But what I have discovered is that you can do the TCVO, can perform the TCVO in a slightly altered manner.
What happened, sir?
I'm sorry?
Is any problem?
Somebody asked something?
All okay, no, sir?
Yes, all okay.
Okay.
So Professor Mittal, we don't have to always perform a second osteotomy. Now, I would not hazard a guess about whose results are superior and inferior. The question that I still ask myself is a second osteotomy really necessary? And truth be told, if I am really able to open up the joint in such a manner that both the condyles make simultaneous contact and the instability is eliminated, I am quite sure that the results will remain as good. I have performed a double osteotomy in about 30 patients. In approximately 45 patients, I have performed only the TCVO. Nobody has come to me still complaining of poor results. It's almost 9 years. So this is a very interesting subject, and we try in our own way to understand and take it further. But I think if we are able to eliminate this instability and give the better contact, stretch out the, tighten the cruciates, there are so many aspects. What about the osteophytes? Why do osteophytes form? Because they're trying to improve the stability, isn't it? That's why osteophytes form. So, shouldn't we get rid of now, for example, Professor Teramoto says, if there's patellofemoral joint pain, don't do the surgery. How can you not do the surgery? I do the patellofemoral release in every patient. It's a must. It's a must. So everything evolves and we add our little bit, do naya paisa add karke, we improve the science and we learn all these. So it's been a wonderful journey in the learning, this intra-articular. I've learned how to do the double osteotomy very nicely. I've learned how to perform the patellofemoral release. I've learned how to do the osteophyte harvest. And I'm most impressed by this focal dome condylar osteotomy. And what was happening, classically, the focal dome is described the vertical limb lateral to the patellar ligament. And that makes the lateral cortex of the tibia very thin. You know, the tibial tuberosity is very close to the lateral cortex. So now what I've started doing is staying medial to the patellar ligament, I am able to go more and more towards the lateral tibial spine so that the hinge point sort of comes at the level of 60%. You know that the lateral tibial spine corresponds somewhere at the top to 60%. So a lot of things we are learning. And if I go, once in a while, I go back to the original TCVO with the oblique sharp downward cut just at the intercondylar level. If you elevate it, take the trouble to release some of the soft tissues nicely and not overdo it and get very good bony congruity. It's amazing the result. The pain relief and the loss and the correction of instability is amazing.
The third question. I have done not many TCVOs. Some of my patients are extremely happy and ask for the surgery on the opposite side also. But some patients whose X-rays look very good, they're not happy. But the same is not true for HTO. Even slight undercorrection or overcorrection, patient is consistently happy with HTO, but somehow the same kind of results are not, maybe it's my technique, it's my poor selection or whatever, I don't know, but I don't have a correct answer to that.
I'm sure you'll find the answer, sir, because I'm sure you've been performing the extra-articular opening wedge osteotomies for a long time. Your technique has become really nice, and that is why you're getting reliable and consistent results. I would not be fool enough to hazard as to why some of your TCVOs are not doing well. But have you performed a patellofemoral release? Have you?
No, I've just done the TCVO. I've just
Yeah,
done.
so I'm sure, sir, you'll find the answer. I'm sure, sir, you'll find. Before I forget, I would be amiss if I didn't point out 2 of my patients are completely unhappy with TCVO. Completely unhappy. 2 of them, for sure. And in one of them, now I suspect I should have gone ahead and sent the patient away for a total.
Okay, but
The reason for those poor results were?
Yes, so one of them I suspect had, significant lateral compartment involvement because, and the patient is simply unable to exercise, is not a good candidate for surgery. And in another patient, I think we undercorrected. We really could not elevate. This is the very beginning. So 2 patients are very unhappy. I'm sure we are going to have our, share of poor results. Fortunately, it's less now. But I think with careful technique, we are learning every day how much to release the soft tissues, that's also an element. If you over-release the medial soft tissues and you're going to set up more instability despite the bones, the condyles being in full contact. So a lot of elements to learn. And this is a subjective surgery. The end point is not the Fujisawa. The end point is not MLDFA of so much and MPTA of so much. The end point is subjective on the table. And what happens is that there is this creep phenomena. If you think that you've reached the end point, and if you wait for 10 more minutes, you're likely to get that little more creep. So this is a more subjective surgery, and we have to be very alert and aware about the many variables that we need to correct. Whereas with an extra-articular, you're going to open the wedge by exactly 9.5 mm. Let's say when you achieve that, you're not looking at anything else. And we are going to be happy with that. So
yes. What I see in your X-rays is that you're performing the transverse cut much lower than what is advocated by Shiva et al.
Yeah, it's just I think you can take
is there a reason for it? Is there a reason?
The reason for it, in many cases, it goes a little. See, the tibial tuberosity sometimes is lower in some patients. Anatomy is not consistent. There are anatomical variations. And I
Okay.
don't want to, yeah, so that's one reason the vertical cut extends a little below. The other reason is in the oblique cut, if it goes down obliquely, you're reaching harder bone. And that enables you to spread it apart without the spreader crushing the bone. And
Yes.
there's no harm in doing it. There's no harm, especially if I'm going to get osteophyte grafts. And the plates that we get, the non-tomophics, that's a non-synthese plates also. There is a variable distance between the ABCD holes and the 1, 2, 3, 4 holes. And it doesn't make a difference. I think a little lower that I go, what I found, if I stayed very high, at the edge of the deep part of the superficial MCL, which is where we start our medial opening wedge, what happens is that the bone tends to get crushed by the spreader.
What
especially
happens
in
with
these
the HTO also?
Yes, sir. Yes, sir. So going lower down is not a problem. Not a problem.
Thank you. So you're muted.
रस्तोगी सर अनम्यूट कीजिए.
Are there any other questions?
No.
I
That's-
think now
Yes, sir.
and you have finished quite in time.
So I would like to finish by inviting again.
yes,
I invite Professor Ravi Mittal. I invite Professor Dinesh Thakkar. I invite Professor Mangal Parihar. And I invite all the great surgeons who are performing high tibial and are championing the cause of knee preserving surgery. Do come. Your presence will be an august, very, very welcome shagun to add the dimensions of the high tibial osteotomies. We know, like India is a country of diversity, knee preserving osteotomies are a diverse bunch of osteotomies. And each one of us is getting good results to great results with different osteotomies. So we are going to be enlightened. We are already having good number of registrations and 3 Japanese surgeons are coming. So Professor Teramoto doesn't speak good English, but his friend, Professor Nobuyuki Takenaka does that. And Professor Nishi is coming, and maybe he will also speak on, nuances that we miss in the translation. I think you're going to enjoy. It's going to be a good time. And I really look forward to having all of you.
Thank you.
thank you so very much, Dr. Milind. Before I close, I would like to tell you about I wanted to put my last 2 slides that what we have done till today. And then beyond this, we have a face-to-face conference on 26th November at Rajkot. Dr. Thakkar is doing that. Then the second one, which you had said, STO 360, and that will take us to the pre-conference workshop on 13th December. So thank you so very much. I hope all of us will join these 3. And I close this conference webinar now. Thank you so very much.
Thank you. Thank you.
Mangal for taking all the trouble to join.
Thank you, sir.
Thank you, Dr. Thakkar, Dr. Mittal,
Thank you, sir. Thank you.
and
Thank
all
you,
the
sir.
parts.